The broadcast is now starting. All attendees are in listen-only mode.
Hi, good morning, everyone. This is Ruth. I just want to let you know that we're going to begin in a few minutes. I see a lot of people are joining the call right now. Good morning. It's 10 o'clock, and I will give it one more minute. Thank you all who are on the line for being on time. Good morning. This is Ruth Colon-Wagner. It is now 10:01, and we're going to begin the webinar. I promise you only 1 minute, and here's 1 minute. So thank you all for being here and joining us today. I'm Ruth Colon-Wagner, Director of Training and Development for NIAPers, and welcome to webinar number 7. Now, if you're thinking about, wait a minute, what happened to webinar number 6? Well, you did not miss it. It was canceled, and that was back in April, and right now it is rescheduled for Thursday, May 31st at 10 o'clock, and so please join us live if you can. And that one is called Actionable Items to Help You Navigate Integrated Care. Today's webinar, webinar number 7, is called More Acronyms, MI and SBIRT, All You Need to Know. So today, Pam Petruzewski, I'm sorry about that, is here with us today. If we could advance to the next slide, I've just got some pieces to talk about. All right, so as always, I really do want to give a shout out to our wonderful partners on this project, and we've got the New York State Coalition for Community Behavioral Health, the New York Care Coordination Program, the Center for Practice Innovations, the Coalition of Behavioral Health, and the National Council. And today we do have our partner, the National Council, doing the webinar today. As many of you know, if you have a new staff member and you want them to join on board for this training, feel free to email me. That's my email address right there on the screen. And we will make sure to give them the proper link so that they can join the training. We only ask that whatever staff join to make sure that they've watched everything that they have missed so far. Because we have that, the second bullet here, we have that recorded on the CMTI website. That actually is wrong. Now that I see it, it says CMIT. That is wrong. It is cmti.niapers.org. So I'm sorry for that mistake. I'll fix it before we get to the next one. And just a reminder, the attendance, we take attendance when you're here live, and we also take attendance when you visit the website and you watch a recording of one of the previous webinars. And lastly, just to let you know, we are still doing CEUs. We're doing social work, CPRP, and CRCC. And at the end of the training series in October, you will receive 10 CE hours. We're still working on licensed mental health counseling, and that apparently is taking a long time, typically takes a very long time. But I will keep you up to date on that as we get closer. Next slide, please. Okay, so this is Pam Petruzewski, and she's with the National Council, and what she does there, she's their integrated health consultant, And she does brief intervention and referral to treatment. And she also does motivational interviewing. And she's been doing motivational interviewing as a trainer since 2011. And she's been training SBIRT since 2013. And before I pass it over to Pam, I just want to let you know that we want you to ask questions throughout. And so we have a question box, and that's on the right panel of your screen. And as you think of the questions, please just type them in there. And what we want to do is set aside two spots for questions. The first is immediately following the content on motivational interviewing. We'll pause for a moment, take a handful of questions, and then we'll do that again at the end. Pam, I'd like to pass this along to you. Thank you so much for joining us.
Great, thank you, and good morning, everybody. As Ruth said, my name is Pam Petrozewski. I'm with the National Council, and these are my two favorite topics. I just think there's so much to be gained from thinking about how we interact with people in a motivational interviewing way. And the SBIRT process is really a foundational way for doing good clinical work that actually includes some motivational interviewing skills. And I know you've had, it sounds like a taste of some motivational interviewing in the context of listening skills in a previous webinar. So hopefully this will build upon that. So if we go to the next slide, what is this motivational interviewing thing? It's MI for short. It's meant to be a collaborative and person-centered method. So it is not meant to be clinician-centered. It's really about us going into that other person's space, their mindset, and understanding from their point of view what they might want to do in order to make healthy changes. So it is also a guiding method. It isn't about just sitting back and being very passive. It does require a dance, if you will, between yourself and the other person to know when to step back and to let that other person talk or express their concerns about a change. And it's also meant, though, to be one in which you are guiding them toward change, not pushing them toward change, because that tends to be ineffective, but guiding them. And it's really about understanding from their point of view how you might strengthen their own internal motivation. So we'll talk about how to get there. Next slide, please. There are 4 processes to doing good motivational interviewing. And we tend to often think about the first step because in healthcare, we are all about engaging and hopefully trying to connect with this other person that we're working with. But we often then go from engaging to planning and saying, how are you today? What concerns do you have? How might we help you? Great, let's get that treatment plan done. Or great, let's get you scheduled to talk to the psychiatrist next. And what motivational interviewing says is that engaging, first of all, has to happen throughout the whole encounter. It isn't about engaging and then moving on and pushing somebody toward change. We have to attend to engaging throughout. So if we find that we are pushing too hard, we have to recognize that and step back and re-engage. And then there are these other processes in between about focusing and having focused conversations around what might be useful if you were to go about making that change. What are the things that concern you, or what fears do you have? And being able to mindfully focus that other person toward what they might want to do. And then evoking with some good open-ended questions, some prompting type comments to really evoke or elicit that other person's reasons. And then if we've done all of those steps, we can move on to planning. Next slide, please. So how we go about doing all of this, and especially the engaging part, is to consider this idea of what's called the spirit of MI, the spirit of motivational interviewing. And it's how we bring ourselves to working with this other person. And so it comes down to these 4 elements of the spirit. And these are things that no matter what words we use or what techniques or strategies that I'll be sharing in a little bit, no matter which of those we pull from, we've got to do those within the context of this spirit, meaning we have to do them with compassion, which is really about understanding and appreciating the other person's point of view, their perspective, their situation, so that it is for the benefit of them, not necessarily the benefit of us. That's what makes it person-centered. So having compassion, having a relationship that's based on a partnership. So it isn't that one person is more an expert than the other, or one person is more important than the other. If we come into this work and we are an expert in family systems or in schizophrenia or diabetes, or any of the reasons we maybe go into healthcare and we become experts in certain clinical areas, we also want to recognize that that other person in front of us is an expert in their own life. And we need both, right? So we hope that they are needing our expertise. That's why they are coming to see us. And to be very open about saying, I really value and need your expertise as well, because I don't know what is going to be the right course of treatment for you. We've got a lot of good treatments. We have some options. I have some recommendations, and I value from you what you feel might work best given your life situation. And that can be very empowering for patients too, if they hear from us that we want to be in partnership and that we see them as an expert as well. The third of the four here is evocation, which is evoking or making sure that we continually ask and draw from the other person their ideas, their opinions, their concerns, because that adds to the empowerment and it adds to the partnership as well. So as much as we may want to just tell someone what they need to do, and we often do that for good reasons, right? We want to give advice. We want to share our knowledge in a given area about what might help someone. We should do that though with also asking and evoking from the other person. What have you already considered? What have you tried before? What is it that you're thinking might be a good next step for you? And then the fourth of these spirit elements is acceptance. So what acceptance is not is just a matter of saying, well, it's your life, whatever you want to do, good luck, because that really lacks compassion, right? Acceptance is, though, about honoring the other person's autonomy and having a sense of accepting that they're coming to us in whatever circumstances they're in, and that's their reality for that moment, right? So accepting that what we might recommend may not be what they end up doing or wanting to do, or accepting that, we may only get 2 steps in to where we wanted to be, which may have been 4 or 5 steps in. And so it's this creating this space where you're going to honor that the other person's decisions. We still may need to clinically say, I'm concerned or I'm worried about this decision, and yet saying that, ultimately it is going to be up to that other person to make decisions that they feel are going to be best. And really, in creating that kind of an environment often makes people more willing to engage with us because they see that they have some control and that we are respecting that they have opinions and ideas as well. So the spirit is something we need to attend to throughout an encounter with another person. So again, the words and things that I'll talk about next, or the strategies, can fall flat if we lose sight of the spirit. Next slide, please. So these are some of those strategies that we can use to create an environment that uses motivational interviewing. And as you may have heard in a previous webinar, it's really about the right listening style. So in motivational interviewing, they have this acronym as well, ORS, which is a way to help us remember these 3 strategies, which is asking questions in an open-ended way, affirming the other person, and using reflections or reflective listening. So I'll explain a bit about each of those, and we can go to the next slide. So the first of these is open-ended inquiry. And the goal of this is to gather, information or to ask questions in a way that help us understand the other person's experience. And it might be a matter of saying, you know, tell me more about what that was like for you, or can you give me an example of how that looked in your life? So it's open questions as opposed to closed questions, which are questions that the person is going to respond with a simple yes, no, maybe, I don't know, I'm fine, right? So questions that tend to start with things like how has it been for you since our last meeting together? Or what are you thinking when it comes to the way we created this treatment plan? Or tell me more about it, right? And you know when you've asked a lot of closed questions because it almost feels like a game of ping pong. When you ask a question and they just say, yeah, and then they wait for the next question. And then you've got to jump in and say, okay, so did you take your medications today? Yeah. And that doesn't give us a lot of information, right? As opposed to saying, you know, how has it been since you started this medication? Hopefully we'll get more information out of that than a question of just, did you take it? So next slide, I do have some examples of how to go from a closed question to an open question. So instead of asking, are you following the treatment plan? You might ask or say, tell me more about the treatment plan and how it looks for you day to day. So if I said, how are you following the treatment plan? You know, the people we work with know what we want to hear, right? The answer is going to be, yeah, pretty much. Yeah, I guess. And then it's back on us to figure out what do I say next or ask next. So a question like, tell me more about the treatment plan, gives them more of an opening to say, well, I'm still kind of confused about the medications, or wait, what treatment plan? I don't even know what you're talking about, which is much more informational. The second example on here, instead of, well, don't you want to see your kids grow up? Which is really not much of a question anyway, right? We might ask instead, what are your goals and what's most important to you? That's less of a judgmental question, and it allows the person to express whatever their goals may be. Maybe it is seeing their kids grow up. Maybe that's not the first thing on their mind, and that's okay too, right? Because this is about going into their space and understanding what is important to them. The third example on here, will you go to the support group? Again, that's really just asking for an answer we want to hear, right? We want to hear, yes, I'll go, but that's not really getting at any amount of motivation. So it's more a question of, how would you go about it if you decided you wanted to try that support group? Because then we could get the person saying, well, first of all, I don't even know what day it's on. Or, well, yeah, you told me about it and I am thinking about it, but I don't even know if I have a way of getting there, right? So that's going to help them figure out how to actually get to that support group versus just a passive question of, will you go? So those are open-ended questions or open-ended inquiry. We go to the next slide, we'll take on the A of the ORs. And that one is affirmations. So what affirmations are words or phrases we might use that support this person's character. It's a testament to their character. Much more than just simple compliments. Compliments are nice, but this is about being a little more substantial in our reactions or statements. We have to do them in a genuine way, right? So it can't be saying something that we don't believe to be true or we don't even know is true. So we need to affirm someone in a genuine way that really reinforces some positive behavior change or positive mindset changes. And it really shows that we're starting to understand this other person, because all of this is, again, about engagement, focusing and evoking from them their reasons and desires for change. So I'll give you some examples of these on the next slide. These come from the Motivational Interviewing book by Miller and Rolnick, and they are words that have been shown to be that successful changers, people that have made successful changes, have identified as being like them. So it might be just a simple matter of saying to that other person, you know, gosh, you seem really strong. You've gone through a lot, and it's really apparent that you have a lot of strength. And then we pause and we let that other person respond to that or react to that, right? They might say, yeah, I guess so, because, you know, my mom died when I was really young and I kind of had to take care of myself for a long time. And the point of using these affirmations, of course, is to support the other person and also to potentially help them use that characteristic in future challenges. So it might be, in what ways do you think you've been strong in this latest problem that you've been trying to think through? It might be to say, you know, you've been very assertive. And some people might say, well, you know, I've been told I'm bossy, but you're saying I'm assertive. So it might be a matter of using this as a reframing for somebody to channel the positive side of what might have been seen or even used before as a negative characteristic. So how do we create an assertiveness and support an assertiveness in this other person that isn't bossy, but is healthy and assertive? The other way some people will use affirmations is if they don't know the person very well, or they're not sure that they could do it in a genuine way because they think that this person seems this way, but they just don't want to take too big of a risk in getting it wrong. They might share a list like this with the person they're working with and say, you know, as I'm getting to know you, I'm wondering, as you look at these different words, what jumps out at you as being true for you? And let the other person tell us, you know, well, I guess, you know, I'm really truthful. As you know, I just kind of say it like it is. Hey, yeah, you are very truthful. You know, how could we use that truthfulness to help you in that conversation, you know, you plan to have later on today with your caseworker, with your family member? So it's another way of affirming and helping somebody move forward. All right, the last one of the ORs, we'll go to the next slide, is reflections. And reflections are what, if we're doing motivational interviewing, this should be the strategy we use the most. What reflections are is saying back what we are hearing the other person say. It might also be saying something we're noticing in the other person. I'll come back to that in a moment. So reflections are meant to be succinct. So if someone comes in and says, you know, 5, 4, 7 multiple sentences, it isn't that we need to hear it all and say it all back to the person, because then they're going to say, you know, that's exactly what I just said. You know, you're being a parrot. But it is meant to be brief comments that show we're listening, that are bits and pieces of saying back the things we're hearing. Reflections are also very powerful because it isn't about pushing the person toward a solution. There is a place for problem solving, maybe even advice, but when we're doing reflections, we're really just right now in the moment with that other person. It's not future oriented. And that's really helpful when people are trying to make their own decisions about change. And ultimately, that's what motivation is about, right? It isn't us motivating someone else. It has to come from inside. And reflections help that other person hear themselves a second time. So the first bullet here says it's, you know, reflecting what you hear. Also, reflecting what you observe can be very useful. So if someone isn't saying a whole lot, we might have to reflect what we're noticing. And it might be something like, the expression on your face really changed when I brought up your father, right? So that is a reflection of what you're seeing. And then we want to pause and give that other person the opportunity to respond to that. They might say, really? Oh, what did you see? I didn't even know that I did that. Or it might be, yeah, I'm really still sad that he's not part of my life. So observational reflections can be very powerful as well. The other thing we want to do is not just simply reflect everything exactly that we hear. We may want to add a little bit more to it. And it's things like maybe substituting a word that the other person used for a different word, still within the context of what they intended, but it's more of a reflection of intent. So if someone says, you know, I am really angry that no one seems to be listening to my side of the story, we might say, you're feeling frustrated, which is pretty much the same thing, right? But it's adding to that person's understanding of their own situation. And certainly we may get it wrong. And if we get it wrong, but we've done it with genuine intent and we've been building that engagement, that is okay, because if the other person is trusting us and hearing us, they can correct us. They can say, well, it's not really that I'm frustrated. It's more that I'm just disappointed because I thought this was going to be a helpful resource. That's wonderful, right? Now we have a better understanding of how they're feeling about it. So the next slide will share a bit about what reflections can look like. So if the other person we're talking with says, it's hard dealing with these voices in my head, I don't always plan to get high, but sometimes it's the only thing that seems to help. There's a number of things we could choose to reflect. We might simply say, it's hard to deal with the voices, because that's what that other person said, right? We might want to add to that and say, you don't always want to get high. Now that isn't what the person said exactly, right? They said, I don't always plan to get high. But in reflecting, you don't always want to get high. What we're trying to do is kind of get a sense of whether that is something they really want or not, without lecturing them, right? Oh, you shouldn't be doing that. That's not healthy. This is a way of saying, it's not something you want either. And then the last example here might be a reflection of saying, you want to find other ways to manage the voices. And again, that wasn't the exact words that other person said, but it's a way of trying to understand their wants and kind of assuming that that is a want. So with that, that is a very brief glimpse of what motivational interviewing looks like. And I promised that we would stop and see if there were a couple questions around MI that we can answer before I move into SBIRT.
So hi, it's Ruth. I've looked at the question box and we've had a couple of questions, but not necessarily regarding MI, more about the structure of the webinar. So right now we don't have anything. I encourage folks to ask questions now specifically on MI, and then we'll do this again regarding SBIRT. So Pam, I just wanted to take a moment, just in case people are typing right now, to really thank you for your detailed description of MI. And I know it was like just a half an hour snapshot of what can be a very lengthy training, but I really felt like you brought it to life with your very detailed examples. And, we've addressed listening before, for example, with using the MI ORs. And that was awesome, but I really liked learning it within the complete context of motivational interviewing. And I felt like you gave us the tools to be able to work in a recovery-oriented and person-centered way. So I just wanted to take this opportunity and really thank you for that.
Good, yeah, thank you. It is certainly something when I do training, it's a good day's worth of training and practicing. But at the same time, to get a flavor for this and to say, as I listened, I realized I don't really reflect. I tend to ask questions and I tend to give advice. But the more we can just reflect and say back what we're hearing, very powerful for the other person to hear. All right, well, let's
keep going because there are no questions yet.
Okay, sounds good. So next slide, what is SBIRT? SBIRT is a foundational way of doing really what this acronym stands for. The first is doing screening. And it's screening specifically. This model or process was created to screen people that are at risk for developing substance use disorders. So, and I'll break down each of these in a moment, but this is the overview. So it's screening so that we are reliably and with validated tools identifying people using substances. Then it's brief intervention, which is really where motivational interviewing can come in. It's raising the other person's awareness of the risks or consequences of using substances, and then really developing their own internal motivation for wanting to make changes and helping them set goals. And the last piece, the RT, is referral to treatment. And it's, in whatever environment you're working, it's if we identify somebody at higher risk use of substances, we want to facilitate, coordinate a higher level of care or an additional level of care to address that high-risk substance use. So next slide is, I think personally, the most important of the SBIRT slides. It's that really this is a paradigm shift in that SBIRT is not looking for addiction. There is no diagnosing in this core SBIRT model. We are merely looking for patterns of unhealthy use. And a lot of that intent is to try to destigmatize and normalize conversations about substances. Because, you know, the thinking of you're going to ask me because then you're going to label me as an addict or an alcoholic, it gets away from the reason we want to do this. It's because we want to just find out, is someone using at a higher level than is what's healthy for them? Or they're on medications that can have counteracting effects to substances, or it puts them at a higher risk for cancer, diabetes, you know, things like that. So we're really just looking for the patterns of use and then creating that opportunity to intervene early, to talk with someone about their use, to see if they're willing to cut back, to do something different, to reduce their risk, to seek treatment if that's something they are interested in. And it's meeting people wherever they are in that continuum. So substance use is not merely two buckets, right? Healthy or non-use versus problem use. There's all kinds of gradations in between that we want to tap into, right? Someone that's starting to increase their use, or someone who used to use at a really high rate and they've cut way back and they've been able to maintain that. So the next slide is a demonstration of what that flow can look like, because SBIRT is really part of a system design, if you will, that it starts with screening. And through the process of screening, we identify that person's risk. And based on the screening tool, it roughly comes to identifying people that are at low risk because they don't use any substances or they use at low levels. Then there's moderate risk, and then there's that high risk use. And any moderate or high risk use, that person can benefit from a brief intervention. It might be a one-time conversation. It might be a couple conversations. High risk use should also include that referral or that coordination of care to other services. And then with either moderate or high risk use, ideally, we want to be able to follow up. We want to check in with the person to see if they followed through on a treatment recommendation or to see if they decided to make changes on their own, so that we don't just make it this, oh, you know, I think you should quit, and then we never talk about it again, right? Because we know that isn't going to necessarily make any changes stick. So I'll break down what these SBIRT steps really look like. In the next slide, these are some examples of screening tools. There are several, and I provided a link to the ones that SAMHSA has looked at. These tend to be the most common, so I included them here. The audit is a screening tool specifically for alcohol use. There's the audit 10, which is just a 10-question questionnaire. There's also something called the audit C, which is a brief, it's the first 3 questions of a 10-question screen that some people will use first. Similar to, if any of you are familiar with the PHQ-9, there's a short version called the PHQ-2, and then you would go on to the full screen if the person was scored positive on the audit 2, the PHQ-2. So similarly, you can do that with the audit. The DAST is a drug abuse screening tool or test. Those are mainly used in adults. ASSIST is one that is a bit longer, but it does then cover alcohol, drugs, and tobacco. So some people like that. And some of these are available in EHRs, so that is also a reason people will choose one over the other. And then there's a couple different tools out there, more than a couple, but a couple really good ones on using for adolescents. One is called the CRAFT, and it stands for, as it says there, it asks questions about riding in a car with someone that's under the influence, whether you use substances to relax, when you're alone, to forget, what have family or friends said about it, and has there been any trouble. There's also a brief screen, more brief screen for adolescents called the S2BI. So the letter S, the number 2, and then the letters BI, which is a very brief 3 questions that often people will use initially with adolescents and then add the craft to it after to get better context around some of these other issues. So many tools out there. They are meant to be fairly short and brief. This again is screening. This isn't an assessment. So it's really a screening, most often done in primary care centers, often done in ERs. I've worked with people in the court system, probation officers using tools like these, mental health centers, community health centers, to do just that screening to understand the person's patterns of use. There is a place for assessment and diagnosis if there's high use, but this is just to screen. Next slide shows how, at least in the example of the audit for alcohol, how it can then risk stratify. So based on the score of the tool, it tells you if the person is at what level of risk. And then the interventions can proceed based on these levels. So a possible dependence, as we now call it, substance use disorder, we can identify that based on a score, and that would be someone that we would talk to about a referral to get a full assessment. And then there's low hazardous and harmful use levels as well. Next slide, when people say, well, what do you mean by risk? There's everything from single occasion binge use to patterns of use, which is the weekly or over time. And some people will use things like this when they're having a conversation with the person around their use. And if it's, more likely that the person is using a lot in short periods of time, then they might focus on some of those single occasion risks. And for someone that's been using at higher levels over periods of time, they may talk more about long-term risks. And it can be very eye-opening, because then you get to hear, not sure if you knew that there's an increased risk for diabetes if you've been using at higher levels over periods of time. Someone may say, gosh, I didn't realize that, and I have a family history of that. Really? You're saying that, having 4 or 5 beers a night actually increases my risk for diabetes? So it's meant to, again, normalize the conversation to get people thinking about their use and how it's participating or contributing to other things in their life. Next slide is the brief intervention, the BI part of SBIRT. The brief intervention, the goal is to raise the other person's awareness of risks, elicit their motivation, and help set goals. This might be a very short, very brief conversation, 5 minutes. It might be a longer conversation, depending on the setting. If you are able to bill for these services, if you have procedure codes, there are certain codes for if it's 16 to 30 minutes versus 10 to 15 minutes. Busy primary care setting may keep it at a very short 5-minute, 2-minute even conversation. I've worked with some mental health centers that will incorporate this into a therapy session, and so it may be 20 minutes or something like that. Next slide. So I alluded to this before, that when we get the results of the screening, this gives us a sense of what that brief intervention might entail. So what we often forget is that if someone tells us they're using at a very low risk, or they don't use substances at all, that's also an opportunity to affirm those choices and maybe even reinforce. So asking a question. So now, drawing from motivational interviewing, asking a good open-ended question of, why is it for you that you choose not to drink any alcohol? Or, you've told me about your family and that, several people in your household smoke marijuana. Why is it for you that you've chosen not to? Because you get that other person talking for their reasons for not using, and that can be additionally reinforcing that low risk behavior. Moderate risk use, the focus of a brief intervention is on how to either reduce the risks or reduce the use itself. So you may be working with a teenager who says, you know, I'm not going to quit drinking. That's what me and my friends all do, and you can't tell me what to do. And as much as we may want to, you know, really push for that, push for non-use, perhaps meeting them where they're at and saying, you know, what are some things you could do to reduce any risks that could come from using? Maybe you can get the kids saying, well, you know, I don't drive when I'm drinking alcohol. You know, we only do it when I'm sleeping over at someone's house. Well, that's a reduced risk. So that's something, right? That's a place to start. Or, you know, I don't drink the hard stuff because I know how that affects me and I didn't like the way it felt. That's reduced risk as well. Reducing use, you know, we often think about wanting people to go from using to quitting. And that's a good goal and an important goal for a lot of people. But we have to keep in mind that may be our goal. And so could we get that person, if they say, I will not go to treatment, I will not quit using, could we explore what it would be like to reduce their use? You know, what would it be like for you if you were to reduce the amount of pot you smoke? Are you willing to try that? What would that look like for you? That other person says, well, you know, it is kind of a drag to worry about the drug testing that happens at my job. So maybe I would use, you know, I suppose I could cut back on using and only use on the weekends. Again, that may not be what we think is best, and we may need to say and feel the need to say, I'm so concerned that that's dangerous behavior, whatever. But if that's something they're willing to try, and we can get them to be successful in that, and we can talk with them about the successes, that's a start. And that's an improvement, and that's something we can build on. And then, of course, high risk. You know, if there's someone using it really high risk, and we've got the tools to tell us what that looks like, then our brief intervention is focused on accepting treatment and, you know, at least committing to coming back to our services, continuing to talk about the potential for treatment, the interest, the likelihood, exploring the right treatment fit, because it's so important that we just stay engaged with them versus thinking that's where we tell them, well, you need to go to treatment and don't come back here until you do. Because that often means they don't come back, they feel bad, they go out and use to spite us, and that's not what we're trying to create here, right? All right, one last thing about brief intervention, go to the next slide. That there are some models that can guide us in what constitutes a good and an effective brief intervention. These are some of the most popular. There's one called the FRAMES model, and it stands for providing feedback, discussing responsibility, giving advice, but then providing a menu of options, using empathy, so important, and creating self-efficacy. What can that person feel confident that they could do? There's also, number 2 here, the brief negotiated interview model, which you'll see a lot of similarities among all of these, right? So that one is about raising the subject of substance use, providing some feedback. Notice they say feedback in that model versus advice. Enhancing motivation and developing a plan. And then the third example here is the flow model. Again, feedback, listening and understanding the other person's perspective, and then what options could we explore together. Probably the most common that I've seen is the brief negotiated interview, perhaps because it's not too short and it's not too long to try and remember. But certainly all of these, you know, they have a lot of the same similar concepts of working with that other person in partnership, right? Using the MI spirit of listening, exploring options, having empathy, and increasing that other person's motivation. All right, the last piece of SBIRT, we'll go to the next slide, is the referral to treatment. And this is a process that is meant to be collaborative and proactive, and it's coordination between whomever has provided the SBIRT elements so far and those that can provide treatment so that that other person not only has access to, but engages with that appropriate higher level of care. And this isn't, you know, kind of the, depending on where you've been, you know, the model sometimes has been, gosh, you need to go to treatment, here's a list of providers in the area. Or, you know, here's what your insurance will cover. Or, you know, we have a relationship with this one treatment center, so that's where I think you should go. And this is about saying, gosh, there's a lot of barriers, right? There's stigma, there's fear, there's maybe, you know, where I want to go I can't afford, or gosh, I'm going to have to travel a distance and that means being away from my family, or I don't have a way to get there, or there's a long waiting list. So in the next slide, what we've been talking about at the National Council is really what I'm calling referral to treatment 2.0. And it's more of this thinking that it's about management and follow-up monitoring. And so it may be thinking about multiple options and other services, such as increasingly we're seeing medication-assisted treatment becoming available in a lot of areas. We've had providers that are getting treated, getting certification to be able to prescribe Suboxone or other medications to assist with the withdrawal of opioids or alcohol, things like that. So are there medications that are available as part of treatment? In addition, medication-assisted treatment may also include individual or group therapy. Is that something that's another resource that that person might be interested in? Is there peer support? The power of peers is unbelievable to me. There's such a opportunity in engaging with other people with lived experience who can help guide this person, can be another support person. That in and of itself isn't, you know, I'm not saying that that's a substitute for inpatient substance abuse treatment, but certainly should be presented as additional support types of services. Group-based treatment. And it might feel really weird to see this last bullet, but you know, ultimately, because this decision isn't ours, it's this other person, no treatment is an option. Now, again, we may need to say, this isn't what I recommend for you, I recommend this instead. However, if you decide no treatment is what you want to do right now, how can we continue to engage together in some self-management strategies? How can we continue to coordinate with your primary care provider? Can we continue to monitor and discuss your use to bring it to levels that will be safer for you or healthier for you? Can we revisit the idea of peer support, right? So that's really what we're trying to get at when we think about all of the reasons people don't or can't pursue traditional treatment, if you will. All right, last slide, and then I'm eager to hear what questions you have. Hopefully this is inspiring you to think about SBIRT, that, you know, when SBIRT starts to stick in an organization, what I've found, and I've worked all over the country, I'm in northern Montana today, of all places, and we've been talking about SBIRT up here on the Native American reservation. SBIRT, when it becomes a model of care, it really replaces those less effective screening methods. I've been in clinics where the question about use has been, do you use moderately, socially, heavily? That's not a very effective or validated means of asking, because what does it mean to drink moderately or to use socially? So we've got some validated tools that can guide us so we aren't just guessing at whether we think this person's use is healthy or unsafe. SBIRT can also help us view substance use on a continuum, that there are biological factors that are associated with use, there are behavioral factors, and how do we meet that person wherever they're at and not just see it as not addicted versus addicted, right? That there's varying levels of use and risk. It can also improve our overall clinical care. As you can see, this model is one that, if you think of screening, brief intervention, referral to treatment, in what way can we apply those steps to other health conditions and other things we're working with people on. It can really become this new way of working that also transforms our culture, because we start to see, how do we approach depression? How do we approach personality disorders? How do we approach diabetes in a way that we are consistently identifying who is at risk for these conditions, who could benefit from collaborative conversations about their care, and how do we coordinate services for additional types of care? And then lastly, it can really prepare your organization and workforce for healthcare changes, because there are so many demands and expectations and ways of demonstrating and providing value. And this is a model that can also help us create best practices and help us be able to show our value when we've been able to say, you know, we really engaged with someone that just really wasn't sure about seeking care, and they felt that they were heard. They were asked questions in an objective manner, and we followed up to see what ultimately ended up being successful for them. So with that, I think our last slide is a prompt for questions and comments. I welcome those.
All right, wonderful. Thank you so much, Pam. We've got a couple of questions, and the first is from Hernan, and it says, what is the best way to implement motivational interviewing with respect to cultural sensitivity?
Oh, such a good question. And I had to think about that this week when I was on a Native American reservation. You know, so I will first say that motivational interviewing from the authors of MI, Bill Miller and Steve Rolnick, have found that it is, in general, it's pretty culturally adaptive, culturally sensitive, in the sense that it is meeting that other person where they're at. And so if the other person, you are using MI in a sensitive way where you are using the other person's words, you're asking and evoking their perspective, ideally you are meeting them in that space. Having said that, there are some emerging both research studies and papers that are being written to give us some feel for how do we culturally adapt. There's something called CAMI, Culturally Adaptive Motivational Interviewing, for Latino and Hispanic people around substance use. Being on a reservation today, I was able to find a Native American motivational interviewing resource. And so a lot of that is about taking into account that other person's culture. So making sure we are asking and evoking, how does your culture play into your feelings about substance use, your feelings about the treatment options that we provided? How does your spirituality play into that? What is it that when you consider family, how do we incorporate that into this? So I hope that gave you some sense of how we might do that. So again, in general, it is intended to be culturally sensitive because it isn't our agenda or our mindset, it's going into that other person's mindset. And then there are some resources out there, or some groups that are starting to study what particular things might we say or do to be culturally sensitive to a population if it's different from our own.
Wonderful. Thank you so much. We've got a couple of other questions. And the next one is, can you share how to use motivational interviewing when you're working with someone who's having difficulty identifying a goal for themselves?
Oh, identifying a goal. You know, I think first of all, we have to consider whether even the word goal is useful. You know, that might be very daunting in and of itself for some people. So one idea is to even say, you know, what would it be like if we just did a trial run of something? So if there's someone you get to see once a week or whatever frequency, to maybe say, what's something you'd be willing to try between now and the next time we see each other? That might have more appeal than I've got to reach this goal. So some people will say, what could you try? You know, could we experiment with this? They might also say, what would be something different? And so that too doesn't sound like this big commitment to reach this goal. And then it's about, really staying humble and saying, I'm noticing that we're having trouble identifying a goal. Maybe that's what I've been pushing. Where are you feeling you'd like to take this next? And taking it next in whatever context is ultimately the goal, right? And maybe we don't have to name it as that, but just say, it sounds like you're willing to do this next. Great, let's go there. So those are some ideas.
Fantastic. So the next question is regarding behavior change and specifically the stages of change, and just wondering, how does MI support that?
Yes, it does. It does. There's the stages of change: pre-contemplation, contemplation, action, maintenance, all those things. What MI seeks to do is, as you are aware of where that person's stage is, framing your language and creating that back and forth that meets that person in that stage. So if someone says, I just don't know, this is brand new to me, I'm overwhelmed, it wouldn't be appropriate for us to jump to the planning stage, right? Or to say, what do you think you'll do? Because they're in a pre-contemplation stage. They're still thinking about this. So then we might ask questions or reflect that stage of change. So it might be things like, you're wondering how to even process this right now, or you're considering what it's going to be like to live with this condition. So using open-ended questions or reflections that acknowledge that person's stage of change and not pushing them to that next one.
Great, thank you. Now there's something that I was thinking about during your training, and it reminded me of when we first did the shift from the traditional medical model to person-centered model, a recovery-oriented model. And years ago, especially back in social work school, they really just taught us how to work with someone, but we didn't learn about client decision, shared decision-making, empowerment a long time ago. But now we have that shift. And so there are some workers that I've experienced that really misconstrue how we are supposed to work with people. And I really appreciated in your training today that you talked a lot, you really highlighted the clinician's role. And so it's not, you could speak to this, but essentially it's not sitting back and just letting the client do what they want to do. You're not following their decision. You're the professional in the room and giving the advice. But I'm just wondering if you could speak to that.
Yes. Yeah. We talk about in motivational interviewing this being a dance. And in a dance, sometimes I'm going to lead, sometimes you're going to lead. And I need to take some cues from you. And in building the trust and in letting you talk about what concerns you and letting you speak from your perspective, hopefully that builds some trust so that when I want to try and take a small lead, you do come with me. And if I'm frustrated because the other person just seems resistant and difficult and not willing to do X, Y, and Z, that's a reminder that I'm pushing too hard. And the other opposite can happen too, where, I've been meeting with this person for weeks and weeks and we're just not getting anywhere. Maybe I'm doing too much following and I do need to step in and acknowledge that and say, gosh, it's feeling like we aren't making progress. What if we reset and figure out what is most important to you? What are the reasons for you why you want to feel better, right? So just tapping into that and then using those reflections to further that conversation, and certainly thinking about it as a dance, that I'm not going to push you too far because then we'll both fall over. If you push me too far, then I'm not being helpful to you. And so the dance metaphor has for me been useful.
Thank you so much. We actually have one more, and it'll be very quick, from Geraldine. If you could please repeat the stages of change.
Oh, yes. And I'm going to miss one, I know it, but there's pre-contemplation, which is not even on my radar. Didn't know this was coming. I had no idea, right? So maybe I just got diagnosed with diabetes and I didn't even expect it. So not even thinking about it. Contemplation, which is, gosh, okay, I know that I have this and I know I got to do something about it, but I don't know what I want to do, right? So contemplation is often this ambivalent stage where I'm thinking about it, but I'm not so sure. Most often people are in contemplation, right? They're coming to us because they want something to be different, but they're not quite sure they want to do all the things that are needed to make the change. And that's a really great place to actually work with people because we want to honor that contemplation stage. And then there's action, where I know I need to do something, so let's make a plan. Or I tried doing some of these things. Those are actions as well. Maybe it's I tried and it was really hard and it didn't work, but there still was some action taken. Maintenance, is an important phase too, where, I haven't had a cigarette for the last year. And, sometimes I'm still tempted, but I haven't gone back and done it. So I'm recovering, right, from that thing I wanted to get better at. And then some people will break it down into even further steps, but really that's the gist of it. Pre-contemplation, contemplation, action, and maintenance.
Wonderful. Thank you so much. If we could go to the last slide, please. I just want to let everyone know that the next webinar is Thursday, May 31st at 10 a.m. Actionable items to help you navigate integrated care, again, from our partners at the National Council. But now I just want to say, Pam, thank you so much for teaching us and really empowering us so that we could work more thoughtfully and effectively with the people that we work with. So thank you so much. And everyone, thank you so much for joining us today. We appreciate it. Take care. Have a good morning. Bye-bye.
Bye-bye.